So I am Amy Adelman. I am the Director of Education and Outreach at Donate Life Northwest. I'm also a two-time kidney recipient, and what kind of spurred this idea is that we are very lucky at Donate Life Northwest because we have access to all these great professionals, and I can really ask them a question anytime I want, which is great for me. But I wanted to give this opportunity to our volunteers and people in the donation and transplant community to also have access to these awesome professionals who are really doing the work in donation and transplant. So I will ask our panelists to unmute themselves and give a quick introduction of their name, their title, and the name of the center. And then we have a question that we'd like you all to start with, and that's, how has COVID changed your transplant program? So Dr. Bennett, why don't we start with you?
Okay, I'm Bill Bennett. I'm the Medical Director of Kidney Transplantation at Legacy Transplant Services. And the COVID-19 pandemic has changed a lot of things, including how we monitor people going in and out of the hospital with masks, temperature screens, and for inpatients, COVID screening. And as an outpatient, we've switched a lot of our visits, routine visits on long-term transplant patients to teleconferencing. And all the professionals and patients wear protective equipment, including masks, eye protection, hand washing frequently before and after and during visits. And so the whole routine of daily life has changed.
Thank you, Dr. Bennett. Dr. Earhart, would you like to go next?
Sure. My name is Sophia Earhart. I'm a heart transplant cardiologist and recently joined the Providence Heart and Vascular Institute. We were in a unique situation because we were just about to go live with our new heart transplant program when COVID hit. So we delayed starting our program until basically the larger Heart Institute had all the resources they needed to make sure there was enough hospital beds and PPE. But now we are live, and with regard to the outpatient arena, we follow about 300 heart transplant patients and have changed a lot of the structure to virtual. So our support groups are virtual, a lot of the follow-up visits are virtual, but if a patient needs to come to clinic, then their visits are socially distanced, and a lot of the precautions Dr. Bennett mentioned are in place. And on the inpatient side, people who care for COVID patients don't also care for transplant patients, such as respiratory therapists and people that help clean the room and whatnot. So, and we've also changed the airflow and more geographic separation to get ready. And so far things are going well, but everything's different since COVID hit for sure.
Yeah, definitely. Dr. Myers?
Hi, I'm Deborah Myers. I'm the section head at OHSU, the Heart Failure Transplant Mechanical Circulatory Support Program. I actually was interviewed to come to OHSU not during COVID, and then ended up doing a move during COVID and basically came to a hospital that was on shutdown mode. So it's hard to say how things have changed because so far since I've been here, we've been in pandemic mode. I have to underscore the comments of the other physicians that have already spoken, that almost every process in the hospital has been modified for COVID. You can't walk in the front door of the hospital without being screened. You can't take the beautiful tram down to our clinics without being screened. Everyone is masked, everyone is careful. There's no eating or drinking, and everyone is masked up to the max. We're very careful about where we put patients. As far as transplants going, our transplant program has actually been increasing during COVID. We've been getting very busy. We've performed a number of high-risk transplants. Everyone's doing very well. We are very cautious about the recipients and the donors. Everyone has to have COVID tests and rapid COVID tests before any kind of surgery. In the beginning, it was very, very hard on visitors because we were allowing no visitors whatsoever. And that was really tough on people that had an ICU stay and couldn't see their family. And it was tough on the family members that couldn't see their loved ones after a complicated surgery. Fortunately, that's over now, and we are allowing 1 visitor per day. So that's a huge relief to the family. Dr. Bennett mentioned that they're switching to virtual visits. We're still seeing our early transplant patients in person, but as we're switching to virtual visits as much as we can, and we have sort of a statewide group of patients. So frankly, for some patients, that's quite a bit easier. So I would say almost everything has changed, but our patients are still doing really well, and our staff has been incredibly heroic during this really challenging time. So there's been a lot of resilience both on the part of the patients and the doctors and everyone else who's involved in this enterprise. Thanks, Amy.
Dr. Maynard, you want to go next?
Hi, my name is Erin Maynard. I am a multi-organ abdominal transplant surgeon, so I do liver, kidneys, and pancreas for OHSU as well as the Portland VA, and am the surgical director of the liver transplant program over at the Portland VA. I would say, I would echo the comments of the other physicians that I would say in every aspect of care, we have certainly changed our management from the pre-evaluation process. We rely on multiple other aspects of the hospital to help facilitate evaluating the patient. So coordinating outpatient visits as well as inpatient. We've started some pre-evaluations with virtual visits so that we can list patients in a timely fashion. And some of them will be listed but inactive until they can be seen face-to-face. From an inpatient point of view, I think it was really difficult early on not having support in the hospital. I think anybody taking care of a transplant patient, going through transplant, or having a loved one that goes through transplant knows how important support is, and not having them be in the hospital in those early periods was very difficult. But I'm glad that we've been able to open up to 1 visitor per day. We've also transitioned our education from actual in-person to being able to have videos available online, which we want to continue through this so people are able to access that education more frequently instead of just one time pre-transplant. And then, like the others, for those patients that are farther out from transplant, transitioning to more telehealth instead of inpatient visits, especially for those patients that are doing well. And then certainly living here in the Pacific Northwest, a lot of our recipients don't live close to a transplant center. So to be feeling well and driving 6 hours for follow-up for an annual visit, I think people are liking staying close to home. I think, as a lot of the hospital elective things shut down for a period of time, preparing for a surge, I'm quite proud that we were able to continue transplant and have kind of our busiest year here for abdominal organ transplant this year, knowing that several of my colleagues throughout the country had periods of time where they weren't allowed to transplant because of COVID and how it hit their hospital. So I think we're excited that despite having to change a number of our processes for the good, actually, we were able to remain quite busy.
Yeah, that's great. And last but not least, Dr. Strassfeld, would you like to go next, and then we'll go into your slides?
Sure thing, just unmuting myself. Thanks, Amy. And so I'm Lynn Strassfeld. I'm one of the infectious disease doctors on the panel, and I'm not a transplant physician, but I work closely with our transplant physicians here at OHSU and at the Portland VA. So as a transplant infectious disease doctor, my charge is to work with our transplant colleagues to decrease risk for infection and treat infections if and when they occur in transplant patients. I also have a significant role at our center in infection prevention and control, and therefore have been very involved with COVID planning in our transplant populations and then hospital-wide. And so to start us off, I prepared just a few slides to serve as an introduction. And largely, as Amy said at the outset, we want to hear questions from all of you, and our panelists will do our best to answer those. Next slide. Okay, so this is a science-y slide to start off with. And what I'll say is that in preparing for today's talk, I have the sense that those transplant recipients or donors or family members who have logged on have some medical savvy or a little bit of interest in the medical background. So I'm not going to go over this in much detail, other than to say that it's a virus, COVID is caused by a virus called the SARS-CoV-2 or a coronavirus virus. And it comes from a bat pictured here. There was initially speculation that it jumped from a pangolin to a human, but now it's looking more likely to be zoonotic or animal transfer from a bat. Not too dissimilar from SARS of a decade and a half ago or so. Next slide. And the timeline, so this I think is really stunning. And I've updated this timeline a couple times in the course of having given talks to different audiences. It really is only December of 2019 when there were cases of novel cause pneumonia that were identified in Wuhan. And then it's only back in February of this year that WHO designated this to be severe acute respiratory syndrome, SARS-CoV-2 as, the named virus that causes COVID. And then the following month in March, WHO declared a COVID outbreak. And then I'll reflect here is that it's kind of early March when I think our lives changed in a substantial way. Like for me as a physician, but also as a mother, March 13th was the day my kids stopped going to school in person. And things have changed in our personal and professional lives since that time. And I don't think we've attained return to normal yet. At the end of this brief slide presentation, I will talk about, because that's an often asked question, when will we get back to normal? And then bringing us up to date since March, as of today, there are over 33 million cases globally, over 7 million in the United States, and over 1 million deaths globally and about 200,000 deaths in the United States. Next slide. For any of you who have looked at the Oregon Health Authority or State Health Division here in Oregon's website, there's a wealth of information on the epidemiology of COVID and also things like preventative measures that individuals or communities can take, groups can take. This is the epi curve, if you will, so the timeline of infection. And what you can see here, it's back in early March when things shut down. And for a while, we had really, quote unquote, flattened the curve. When we eased our restriction and our isolating practices is when COVID activity increased in our state. And in response to re-roll out or restriction of activities in the community, we saw some decrease in cases. Time will tell where this curve goes. My own sense is that it'll kind of go up and down over time and wax and wane. Until when, we'll get to that. Next slide. And so why are we talking about COVID in the solid organ transplant population? I think there are three main reasons. One is because patients who have had, you can go back, solid organ transplant are immunosuppressed. So by virtue of the medications that patients are on to prevent organ rejection, they're at higher risk typically for infection after the transplant. They can have, transplant recipients can have different clinical presentations and usually more severe clinical presentations of infection. But there is some speculation here that the immune suppression that's used to prevent rejection may actually be an aid in decreasing this very intense inflammatory response that occurs in patients who contract COVID. And I'll talk very briefly about that. The other reason why patients being immunosuppressed makes them higher risk is that they shed viruses for a longer period of time. And we're still trying to ferret out the implications of that for transmission or passing on COVID if a transplant recipient has COVID. Next slide. Next. So this is the most recent study that was released. And this is looking at outcomes of solid organ transplant recipients with COVID. And this was over 300 kidney, pancreas, liver, heart, or lung transplants that were transplanted at over 50 transplant centers in the United States. Next. And of these, it kind of mirrors the population at large in some ways. So these 80% or nearly 80% of these patients required hospitalization, but I'll add a big caveat here in that they didn't do a lot of screening of asymptomatic patients in this study. So there were likely more ill patients that were included in this group. And of those that required hospitalization, about 40% needed to be cared for in an ICU, and a little less than a third required a breathing tube or required mechanical ventilation. And of those who were hospitalized, unfortunately, 1/5 of those patients ended up dying within 28 days after diagnosis. What I will say here, though, the risk factors that were associated with death in these patients were the same risk factors that we hear about in the community at large. So those are patients who are older, older than 65, and have what we call comorbidities, other medical conditions. So similar to the general population, transplant recipients with other medical problems are at higher risk. Next slide. And so another reason why there's been a lot of focus on COVID, and we're here talking about COVID in the solid organ transplant population, is that patients who have had transplants have a lot of contacts with the healthcare system. And so as Dr. Maynard mentioned, there have been numerous centers across the country that have had to cease their transplantation in the context of COVID to decrease risk for transmission in the healthcare setting, bringing lots of patients in the hospital. Next slide. So this is some data from UNOS. Again, it's available on the web. And what we can see here, this is data for the whole country. And year-to-date data you can see here through late September. And it looks like living donors had fallen off significantly, and that's because a number of centers across the country put a hold on their living donor transplants when things were shut down in March and April, but have since opened up. Next slide. And this is data for the Northwest in particular. And I guess when we compare, if you look at this UNOS website, Northwest to regions like the Southeast or the Northeast, we've been fortunately able to track cumulative transplants to almost on target where we were in 2019. And by we, I mean as a region. And as Dr. Maynard mentions, here at OHSU, we've had a year-over-year increase in the number of abdominal transplants that we did in this past year compared to the year prior. So I think the situation in Oregon as it relates to case incidence and the ability to institute protective measures early on in the pandemic has allowed us to continue operating from a healthcare standpoint with safety relative to other centers in the United States. Next slide. Okay, and then lastly, I'll bring up here why we talk about SARS, COVID in the solid organ transplant recipient population specifically is the always present concern for risk of transmitting SARS-CoV-2 or COVID with organ transplantation. Next slide. And what I will tell you is that there have been to date no cases of organ transplant transmitted infection reported, which I find reassuring. And so what that tells us is probably a combination of factors, that this isn't a virus that is very readily transmitted by transplants in donors who are carefully selected by way of screening for COVID by testing the donors, and also by screening for symptoms in those organ donors. Next slide. And so the last question here is, when will this end? And I think that really hinges on a couple of endpoints. Our ability from the standpoint of public health to bring the virus under control. And that's really more of a public health commentary than it is infection control or specific to the transplant population. Next. The timeline for a vaccine, which I know probably as much as all of you on the call know, that the anticipation is that sometime late in the calendar year, a vaccine will become available. I know the prioritization for vaccine will be first for vulnerable populations, which include transplant recipients and those of advanced age. But the specific timeline still eludes us. Next. And then lastly, how effective the vaccine will be. So there are some vaccines that are super effective, like the MMR or measles, mumps, and rubella vaccine, which in sufficiently vaccinated individuals, we scarcely see a breakthrough infection. And then there are other vaccines like the influenza vaccine, which are certainly important and decrease risk for severe infection, but don't completely eliminate risk. And there are a couple of different vaccine models that are being worked on for COVID, and time will tell which one is first to be approved and used. What I will say is that the first COVID vaccine probably won't be the last COVID vaccine we arrive at. And the next slide, which is my last slide. Oh, I have actually a couple more. So in the meantime, heeding advice from public health and from the provider teams that you interface with, wear a mask. A mask is to protect people around you. There is potential for asymptomatic spread of COVID. And so we recommend that anybody who's not living in a household together wear a mask indoors and outdoors. Next slide. And then abiding by social distancing, avoiding crowded situations and close physical contact with individuals outside of your household, specifically in an enclosed space for prolonged periods of time as possible. And next slide. And then these are the COVID vaccines that are currently in late stage clinical development in phase 3 trial. Next slide. So I think we can end there, that's fine, and see if there are questions from the group. I don't have any more data to present, but I can call upon some of these slides if we need to address questions from the audience.
Great, thank you so much. That was very helpful and a great introduction. So I'd love to now open it up for questions. Does anyone in the audience have a question? You're welcome to unmute yourself, or you can put a question in the chat box, whichever you prefer.
I have a question.
Mm-hmm.
Will the vaccine be a live vaccine? And if so, can transplant recipients have that?
Thank you. That's a great question. I anticipated that question. So none of the vaccines that are in development, in phase 3 development, or even in early stage clinical development from my research on the topic are live virus vaccines. So they're all either mRNA constructs, they're genetically made vaccines, or they're inactivated vaccines. So all of them will be safe for delivery to transplant recipients. Yeah.
Great, thank you. Someone have another question? All right, we will move to.
I actually have one.
Oh yeah, go for it.
It's not necessarily for Ms. Strasfield, but so I'm due for all my annual testing. And do I have to have a COVID test before each one of my separate testings that I have coming up?
So do you want to direct that question to a heart
Yes.
doc? Okay, so that would be Sophia or Dr. Myers. Would you like to talk about what your center does when someone comes in for testing, or like their annual checkups?
Sure, happy to.
Sure.
So it depends on what you're getting done for your annual testing and kind of institutional policies. And I think as we're learning more and more about COVID, this is probably changing because COVID has changed, transmission has changed and whatnot. But in general, we're recommending screening for invasive procedures or things like pulmonary function tests where you're breathing right on something. But for echo, then usually you don't need COVID testing before. I would hope that it would be so organized that you would only have one screen and wouldn't have to go through multiple screenings. But it's usually within a few days prior to your testing. So if you have all the testing organized on the same day, then you should only need to be screened once.
So for the echoes and chest x-rays, no screening necessary, but for the angiogram, there would be screening necessary.
Yeah, that's our current protocol.
Perfect. Thank you.
And Dr. Myers, at OHSU?
It's very, very similar. Certainly any procedures that involve aerosol or testing or intubation. So generally elective surgical procedures require COVID testing, particularly when there's a high chance of exposing a large group of hospital staff, say in an OR or in a cath lab. But for things like a clinic appointment or for, lab testing, we do not require it. Some of the patients are actually calling me with questions and saying, I'm worried about going to a commercial lab because I'm worried about going and getting my bloods tested in the, in a general population where I'm going to be in a waiting room with a bunch of people. And I've actually started asking them to call the lab, find out what time they open, and could they actually be done first, to even ask if they could be done first before lots and lots of people come through a waiting room. And in general, people have been pretty accommodating about that as well.
That's a great point, Dr. Myers. So just being in contact with your lab and making sure that when you go there that you feel safe and that they're taking the precautions that are necessary. That's
right.
Really
and then the other thing is that we're telling, all of our transplant patients, because of the, presumptive risk of the increased chance of getting COVID or the increased severity of disease if they do come down with COVID, we're just stressing to people, be really, really careful. And I also want to make a plea. We have holidays upcoming, and I think everybody really has to think about, of course it's a loss if you can't get together and do the same traditional holiday that you've always done with, 25 people, but it's something everyone has to think about because, it's not worth it. You see these stories about people getting together for a wedding or other life experiences, but we've got to play the long game here. And so we're starting to talk about that a little bit in clinic as well. How to have a happy, loving holiday without necessarily putting yourself at risk, okay?
Zoom holidays, right? That's what Zoom's for.
You can think of lots of creative ways to get together, but everybody needs to be safe, right?
Yeah, definitely. We've focused a lot on recipients, and I know there's at least one living donor in the call, so I'd love to get to a living donation question. Dr. Bennett and Dr. Maynard, if you wanted to this. So one of the questions is just, we've been focused on recipients and their risk, but can you talk a little bit about living donors and what their increased risk, or if they do have an increased risk, and what that may look like for a living donor? Dr. Bennett, can you, Carol? I think you have to unmute. There you go.
Yeah, I mean, living donors are actually pre-selected to be healthy. So they theoretically should be at the lowest risk of anybody if they unfortunately got COVID. I don't know of any special precautions besides what has been emphasized already to be taken by potential living donors. The living donor has about 60 to 70% of normal kidney function, and even that degree of mild kidney dysfunction should not predispose the living donor to anything special. So living donors need to do what everybody else does, in my opinion.
And would you say they're at a higher risk than, say, quote unquote, normal population?
No, I would say they're probably at a lower risk because they wouldn't have been selected as a living donor if they weren't healthier than the normal population.
And then we did have a specific question that's around the same topic, so I want to get to this. This person said, I'm 74 and in great health for my age, but I only have one kidney. Am I more at risk for exposure? I think I know what your answer is going to be, but I had to ask it.
Well, if they have one kidney and it's working fine, the answer is no. If it's not working fine and they have some stage of chronic kidney disease, then probably they are at an increased risk. It would depend on what their kidney function was at age 74.
Great, thank you. Anyone else want to add anything on to what Dr. Bennett has stated? All right. Next question. Does anybody have another question?
Amy, I was just curious for any of the physicians, what is your practice for this flu season? Is it going to change anything you're doing for living donation for this flu season and vaccination?
Ours is not. We encourage people to get an annual flu shot, and they're available today and at Walgreens and every place else, and you should get one.
Is there, I know there was some literature in the past about maybe doing a booster, or I don't know if it was a second or anything like that. You're not doing anything unusual like that,
No,
or I guess I should say unusual.
We're following what the CDC recommends this year, and just a standard flu shot. And if you're older, you get the high potency flu shot, and just regular guidelines.
Dr. Maynard, do you have anything to add to that?
Yeah, I think Dr. Strasfield could probably add some more in terms of kind of the higher potency versus the lower potency and what we would recommend for recipients.
Thanks, Dr. Maynard. So there, just like Dr. Bennett said, for individuals who are older, the high dose flu vaccine, which is actually 4 times as potent as the standard dose vaccine, so it's not really just the double dose, is the one that's recommended for individuals who are over age 65. And there is good data to support that, with decreased risk of infection with the high dose compared to a standard dose. In immunocompromised patients, like transplant recipients, we, and by we I mean the ID community, infectious disease, do recommend a standard dose, a high dose as opposed to the standard dose in transplant recipients of all ages, because it's a more of an immune boost, or it's more protective, even in younger patients. But the issue sometimes is having insurance companies cover that. So if you're a transplant recipient and you're less than age 65, I would give the advice that the high dose vaccine is the preferable product, provided your insurance covers it.
That's a great point. Thank you.
Would that also apply to the people that we live with? I know they're supposed to get flu shots as well.
That's a good question. So thank you. Everybody you live with or everybody you have contact with should get a flu vaccine, but they should get a flu vaccine that's age according. So, yeah.
Lynn, do you want to comment on any of the data coming out of the Southern Hemisphere that they're noticing that there's been because of all the mask wearing, social distancing and precautions, what the impact has been on their winter flu season?
Yeah, I do and I don't. So thanks for bringing that up. So yes, Australia has seen in the Southern Hemisphere like a marked diminution of influenza case counts in the context of social distancing and mask wearing, but that does not mean that y'all shouldn't get a flu vaccine. So we still want to hit hard on getting vaccination, because having flu surging at the same time as COVID is just really the recipe for things going even more wrong from a public health standpoint. So we're hopeful that we'll have a more mild flu season, but that also depends on everybody social distancing, wearing masks, and getting a flu shot.
I have another question about masks. Are we safer wearing N95s than just like the cloth masks? And if so, how long can we re-wear them?
I guess I'll take that one too, unless anybody else wants that question. So that is a tricky one. In a healthcare worker who's fit tested, we do recommend an N95 mask for healthcare workers or anybody in the hospital staff who's going to be in the direct environment of a patient who has COVID or suspected to have COVID and is having what we call an aerosol generating procedure. So meaning like a procedure that allows aerosolization of respiratory secretions. I don't want to use too much technical language. We think that largely in mass, COVID is spread through droplets, which you can actually markedly decrease risk for transmission of by wearing a mask if you're the affected or non-infected individual. If it's an aerosol, then masks like cloth masks aren't as effective. I would say the population at large is not fit tested for an N95, and it's not recommended. And then how this all started and played out in the public health / political landscape was that there were shortages of N95, so they weren't recommended for general populations. I would still say I wouldn't recommend an N95 for a patient in the community or in the hospital. So, social distancing, ensuring there aren't ill contacts nearby, careful attention to hand hygiene and things like that are really going to go a lot further than I think perseverating on using healthcare grade masks in the community setting. Does that answer your question? Because largely it's spread by droplets. Individuals aren't fit tested if they're not healthcare workers, and it's just simply not a tenable approach.
And I want to give a chance to Dr. Earhart and Dr. Bennett. Do you have anything to add or reiterate of what your centers are doing?
We're doing pretty much the same. The fitted N95s are used in the hospital for staff and people that are working with transplant patients and COVID patients, not the same people, of course. And in the clinic, most people use cloth masks, and we're religious about social distancing and the rest of it. But I would agree with Dr. Strassfeld that it doesn't seem realistic that everybody should get fitted for an N95.
Yeah, I agree as well. And it seems like in the community at large, as you point out, not everyone knows how to wear them as well. And if they're not worn properly, then it doesn't have the same effect. And I also think they're not as comfortable as a cloth mask, which may lead to challenges wearing it all the time. With regard to the hospital for aerosolized procedures, where you might have deeper secretions, then we wear N95s, but otherwise we wear a cloth mask with a face shield. Perhaps Dr. Strassfield can talk to the evidence behind that, but I think it's just a double protective mechanism that makes people feel safer.
Sure, thanks. So I'll show you, this is my mask that I walked into the hospital with today, and I'm not having patient-facing contact. So this is a routine cloth mask. It's from Old Navy, and this is what I wear in the community and what's generally recommended. Although I have access to N95s, I don't think use in the community is the appropriate approach. In terms of eye protection, which was just brought up, so there is concern in the healthcare setting when virus is aerosolized in the context of procedures being performed on a patient, or that there's transmission through mucous membranes around the eyes, either by direct inoculation, like touching your eyes, or actually just aerosols landing in that area. And that's why in the healthcare setting, we recommend folks, or we advise them to wear eye protections, like a shield or goggles covering their eyes, as well as the mask. But I wouldn't recommend that for community usage.
So we did have another question come in, and it's asking, do different types or different blood types fight COVID differently? So is one blood type better, or does a better job at fighting the virus than other blood types? Whoever wants to take that.
I would say Lynn can correct me if I'm wrong, but I don't know that there's any data to support that one blood type is defended or is better able to fight off COVID than the other.
Yeah, I would agree with that. So early on, there were some concerns that AB blood type was associated with more severe infection, but those have largely been discounted and really don't rest with logic or valid scientific explanation. So I don't think so. And then the other thing is that your blood type is immutable. So you can't change your blood type, and you still have to use all of the precautions we've discussed to prevent infection. But I'm not convinced by that literature.
Great, thank you. So another question that we had is, if a transplant recipient or a living donor were to contract COVID, what is the risk to that organ? So for a living donor, they only have one kidney. For, a lung recipient, a heart recipient, a liver recipient, pancreas, liver, or pancreas, kidney, what is that risk to that transplanted organ, or in the case of a living donor, that one organ? And this is to all the panelists. So why don't we start with Dr. Myers, because we haven't heard from her in a little bit.
Well, I'll have to defer to Lynn on this, but my understanding of this virus is that, the main risk isn't necessarily just to that one organ that's been transplanted. COVID is widely now, considered, it has a pulmonary entry, but it has sort of diffuse vascular effects. So a number of people that are hospitalized with pulmonary COVID, about 60% of them now, particularly if they're are known to have some cardiac involvement, sort of a low level of myocarditis, acute kidney injury is common. Clotting is the clotting cascade, probably because the inflammatory mediators are upregulated, so clotting is increased. So the risks are kind of a larger risk than just that one organ that's been transplanted. Lynn, do you want to comment on that?
So just like you said, Dr. Myers, COVID, we're appreciating more and more, is a multi-system disease related to the SARS-CoV-2 virus. I don't know that the transplanted organ bears special risk, apart from lung recipients have been shown to have a more difficult course, largely because it targets the lungs, the respiratory system primarily.
Dr. Bennett or Dr. Earhart, would you like to comment?
I would reiterate that just working with kidney transplant patients, first the donor, again, the donors are healthier than the general population if they get, and usually younger. And so if they get COVID, it probably is going to be a mild disease. The people that have had problems with kidney failure or kidney injury are people that are hospitalized on respirators, desperately ill, and sometimes they get multi-organ failure. In the kidney transplant population, though, it's largely been a mild disease that acts like other viral infections. Usually the immunosuppression, the baseline immunosuppression is reduced. We don't have good evidence that that is useful, but we do it anyway. Usually people get over it and without any resultant loss of kidney function or transplanted kidney function. So if you're really sick in an ICU with COVID, yeah, you can have kidney failure. And if you're a transplant patient, that would include your transplanted organ. But most cases in kidney transplant patients, according to the University of Washington registry and every other thing I've read, have been mild. And most of the severe cases happened early on in the New York area that led to dialysis and all that stuff.
Dr. Earhart?
Yeah, I would reiterate the sentiment of the group. There's no data that I've seen that the heart transplant or organs other than lung transplant are increased risk from COVID other than the native organs, basically. And a lot of times, as we talked about, probably related to the immune reaction that the virus can trigger, patients on immunosuppression have a milder course.
Dr. Maynard, anything to add?
I would say from kind of a liver perspective, I would echo what Dr. Earhart says about the heart, that we haven't really seen that liver transplant patients are at increased risk. But if they do get severe disease, like anybody that would have a normal liver, a non-transplanted liver, if they're sick, we can see a decline in liver function. But as they recover, their liver should recover.
Great. Thank you, everyone. We had another question come in. It's about dental care, which is interesting. I didn't think about that, but that's a good point. Should transplant recipients be doing their routine dental work? And is there, risk going into a dental office? And what would be your recommendation to your patients?
I would recommend my patients get their routine dental care. I think that, it's the dentists have been in the community, and I know this because I've seen 3 dentists in the last month. They are absolutely fastidious about having you text them from the parking lot, coming down and questioning you, taking your temperature, wear your mask until you're in the room. They are absolutely, the word has really gotten out to the dental, to the dental community. So I think people are very safe doing that.
I would agree with that. The dentists have been if I've been to the dentist recently, and they're unbelievable in terms of their safety precautions.
That's great. Really good to hear.
I
Anything
think
to add?
what we would worry about is that people kind of ignore their dental care, being concerned about catching COVID, and then they ultimately get an abscess or an infection in their mouth that makes them sick. So I think that they're far safer going to the dentist than getting an infection in their mouth.
Great point. So yes, go get your dental work. Thank you. Let's see. Are there any other questions? I can go back to I want to make sure we give everybody a chance. Okay. So another one of the questions is, what do you tell your patients? So when they come into clinic or when they're making their clinic appointment and they're really nervous about coming in, or they have concerns about entering a transplant center, what do you tell your patients, and what do you do to kind of reassure them, or take the precautions that they need? Whoever. Start with Dr. Bennett.
I'm the lowest letter in the alphabet, I guess. We discuss it with them, what our precautions are, what we do, and offer them the telehealth option if it's a routine visit and there's really nothing new or different that needs a physical exam, and particularly annual follow-ups and that sort of stuff. And a lot of people, as was said earlier, like not having to come to Portland because of the chaos in Portland and the smoke and traffic and everything, and they're happy to not come. So we tell them what we do and then leave it up to them.
Great. Dr. Earhart?
Yeah, I agree. I think giving them the choice if it's routine care for a virtual visit, if they feel more comfortable with that. But I also think for patients who haven't been seen in a while, or for patients who have new symptoms, in-person visit is more thorough. And I would let them know that we follow the CDC recommendations with regard to masking and distancing. And I think it's also important to understand that the outpatient arena is very different than the inpatient arena. On the outpatient setting, if people are sick, then we don't want them, with symptoms of COVID, then we don't want them to come to clinic. We want them to get tested and then isolate and treated. So we're not bringing those patients into clinic to be seen.
Dr.
I think on the kind of consenting side of things from a surgical standpoint, when we're consenting the patient when they get called in for organ transplant, and admittedly early on in the process, we had a lot of patients who were nervous, even if they were incredibly ill, were very nervous about going through with transplant. So what we were doing was, one, kind of counseling them on the donor testing. So every donor in this area, including living donors, gets tested twice for COVID. Sometimes it takes quite a bit of time to evaluate donors, including deceased donors. So if the testing had been longer than 3 days, we're repeating testing on the donors to make sure that they didn't come in asymptomatic. And I also let them know that despite testing negative, if there was any question, so if they had an unexplained respiratory illness, we weren't proceeding with transplanting those organs. And then I also explain, what our protocols are in the hospital to keep them safe and post-transplant, and then just go over some of the data prior to consenting them. All patients are also getting screened by phone before they come into clinic and get called in for an organ transplant as well.
Well, that's great information to have. Dr. Myers, do you have anything to add? Oh, you're muted.
Yeah, I think that what we're really talking about here is competing risks. And that's something that as adults and as people we deal with all the time. What's the risk of coming in to get your routine care versus not getting your routine care and having something missed that could be a problem? And again, in transplantation, when we're dealing with patients with end organ disease, that's usually pretty serious and potentially life-threatening. And so, the risk of transplant then becomes, relatively small compared to the risk of getting really sicker from an end organ failure that you might have. So, it really is like anything else. It's like, we just have to make our mind up. Well, we have to go to the grocery store because we have to eat, right? And what's the risk of not eating? Well, that's pretty significant, but yet we take those risks because we know that it's a balance of those risks. And I also want to say that as difficult and as stressful as this COVID situation has been for everybody, the healthcare workers, the recipients, the families, we really have done a relatively good job here in Oregon compared to a lot of other parts of the country. I think we've had a relative compliance with masking. I did see two people in masks hugging each other that didn't seem like they'd seen each other in a long time in the lobby today. So people aren't fabulous at this. There's always room for improvement. But at the end of the day, we've done a pretty good job, and we're pretty lucky so far in Oregon. And I think it's been because everybody's pulled together to get this done. So I just wanted to make that comment.
Yeah, that's a great point. Yeah, I mean, I see the same thing. I think, for the most part, all around our community, people are pretty good about wearing masks and being socially distant. And it definitely, I think it feels safer than some of the things that we see on the news or around the country. So that's great to hear. One other question that I just wanted to kind of start to wrap things up, unless anybody else has another question. I just wanted to check in real quick. Any of our participants? All right. So I have two final questions. One is just what would you recommend to your transplant patients? We've talked about masks and all of those lovely things. What do you tell your patients when talking about a COVID and you're seeing patients? So just again to reiterate, and I think this can be to any one person, or we can go around robin to all of our docs. I'll call on Dr. Maynard because you haven't started yet.
So I think, I would reiterate what Dr. Strassfeld had said earlier, that any transplant patient, one should do basic precautions. So making sure that they're wearing masks, socially distancing, washing hands. And I think the one thing that we've kind of touched on is not kind of ignoring your other healthcare over kind of concerns for exposure. I think making sure that you're continuing your routine healthcare and checkups, whether or not that's virtually or locally, will be important in terms of making sure that you stay healthy.
That was great. Anybody have anything to add?
I would add one point. It's logical if you get a viral infection to conclude that you're immunosuppressed, so therefore you're more prone, and therefore you should lower your own dose of immunosuppression. And so we tell people definitely don't do that. And because, as was said before, the routine, your other health issues, your diabetes, your heart disease, et cetera, need to be taken care of, or you'll get really sick if you get COVID. So.
Great point. Take your meds.
The other thing I'd like to add is that it's really important to stay healthy in a broader sense. So it's really important for people to figure out how to exercise safely. They can't go to the gym and breathe on each other the same way that they used to, but for particularly heart transplant exercise, and I'm sure for all transplants, cardiac rehab and just getting exercise is really important. So you have to figure out how to do that in a safe, sustainable way. You can't be too careful. And then the last thing is, we do see spikes around the holidays where people just sort of throw caution to the wind. So I just want to really reiterate to people to start making safe, sustainable, and fun plans for the upcoming holidays.
Great point. So my final question, you all know what it is, but they don't. So I'm going to read it. Now that we've nearly been through this, about almost 7 months, which is crazy. In October, it'll be 7 months. What are your expectations for donation and transplantation for the future? And I'm going to start with, let's start with Dr. Earhart.
Yeah, great question. I think, as Dr. Strassfield pointed out, there's still a lot of unknowns with regard to COVID and the trajectory of things. I'm hopeful that we'll have a good vaccine and then it will be an effective vaccine that a lot of people have quick access to. But at the same time, everything has changed and I don't think it's quite a new normal yet. But I do think that we're getting more accustomed to transplanting safer from both a donor and a recipient perspective. And transplants still need to happen because there's sick patients that need them. And I think that our systems have accommodated to do that successfully, and that's very encouraging. But we'll have to continue to be very detail oriented and safe about the processes that we put in place to ensure that that's still done right.
Great. Dr. Bennett?
I would reiterate that. I think we're going to learn a lot more about this infection and other infections over the next several months. And I'm probably the only one on the panel of physicians that's old enough to remember before 1980, we thought HIV was a terrible disease that we couldn't transplant because everybody would die because they were immunosuppressed, and now it's routine to transplant HIV positive patients. So I think transplantation will go on. The molecular biology is becoming more known, and I'm optimistic about the future. I think we'll do many more transplants and help many more people.
Dr. Myers?
Yeah, I would agree with that. I think that transplant, I'm heartened by the data that Lynn Strassfield showed, showing that we really haven't taken a big hit in terms of the number of transplants that are being done. And I'm really pleased about that, because I think it is really important to the people that are living with end organ disease and to help them live the rest of their lives. So I'm really glad to see that we're all still soldiering on despite this. And I think I also caution patients that we're not, this is going to go on for a while. If you look at the history and you look at the 1918 flu pandemic, the Spanish flu, I mean, this is something that really impacted society and for about 2 years. And I don't think it's going to be something that's going to go away completely. And I think we have to be kind of prepared for that too.
Dr. Maynard?
I think, as much as we've, grown and evolved and adapted and changed our protocols, I anticipate that as we learn more, we'll have to continue to change and adapt. And I'm really proud of just the transplant community as a whole. There's physicians from several different centers here, but I think the transplant community as a group has worked together to come together to share data so we can learn from one another. And certainly, we'll have new decisions to make in terms of what happens to a donor that had a history of COVID but now is negative. Will that be safe to use? What is the best waiting period for recipients that have had COVID, and when can they safely be transplanted? And so I think as much as we know, there's still a lot to learn.
And Dr. Strassfeld.
I don't have anything new to add. I'm encouraged, and just picking up on what Dr. Maynard said, the one clinical study that I showed you was really outstanding and stunning to me in that it was a cooperation among more than 50 transplant centers across the country. So while there's a lot that's still undefined at this point, there's, yeah, certainly with all the collaborative work, I think we'll sort through this and figure out the best way forward safely.
Great ending note. I have just a couple things related to Donate Life Northwest. Of course, I have to put in a couple of plugs. So I'm going to share my screen for just a second. So we do have Halloween coming up. This would be a great way to socially distance and spread awareness. So we have our Halloween hero hangers. You can order those now, and a great way to celebrate Halloween. We also have National Donor Sabbath. If anybody is interested in participating in National Donor Sabbath or just want more information about it, please email Caden and he can talk to you more about kind of what we're doing this year. We're hoping to have a great virtual presence during National Donor Sabbath. So look for those, and if you're interested in being involved, you can contact Caden or myself. I also just wanted to say a big thank you to our panelists. Thank you so much for taking the time to inform our community. I thought this was a great discussion, and I hope that you all got the answers that you needed. If you do have further questions, you're welcome to reach out to me. I can reach out to these physicians and hopefully get some of your questions answered. And I want to thank everybody who is participating, or who participated. Thank you so much. I hope you have a great evening, and check out our volunteer calendar. Thanks again. Bye-bye.
Thank you, Amy.
Thanks, Amy.
Thank you.